From the 1st of July, taxpayers would foot the bill for cancer drugs administered in private facilities for private patients.
In this instance, the beneficiary is private health insurers. Because many of the people who will be going to be treated privately are either people that have enough savings of their own to do so, or have private health insurance. People who can't either save a lot or can't afford private health insurance don't get a leg in this at all. It's essentially a backhanded subsidy to private health insurers.
So if you don't have private insurance, or you're not quite wealthy, you can't access this. So it's a publicly funded cancer drug that's only available to the wealthy and sorted, the ones who have insurance or just a pocket full of thousands of dollars. That's wild. I can't believe that this isn't a bigger story. Welcome to another episode of The Frontline. I'm Dr. Gary Payinda, and we're going to be speaking with Ian Powell today. For 20 or 30 years, he was the head of a union of public hospital doctors. I should mention that I am part of that union that he used to head up many years ago. And in that role, he got a great perspective on how the public healthcare system in New Zealand works and how it could work better. In an article of his, he talked about the outsourcing of surgery in New Zealand and a whole lot more. Some of the things he talks about in the next 20 or so minutes with us: public-private partnerships that hold the public sector to ransom, 10-year contracts given to private sector healthcare businesses, 10-year contracts that the public sector would love to have but could not get. Funding going to urgent cares and telehealth companies, paying them 2 to 4 times more than a family doctor, a GP, would get to see those patients in the current system. The inability of Health New Zealand to not just recruit, but also retain doctors and other healthcare staff. The cherry picking that happens in the private sector. The loss of staff that occurs as we put money into the private sector and not the public. The hollowing out of our public sector. This is a good interview. It gave me a lot of things to think about. I hope it will also be worthwhile for you. And the last quote I'll leave you with before we get into the interview is: healthcare is not a commodity. It's a public good, an investment in our future. Those are the words of Ian Powell. And we look forward to having him on the front line again in the future. So for now, sit back and enjoy our interview, and like and subscribe if you want to see more of this kind of thing in the future. All right. Hello, Ian. Thank you for joining me on the front line. Would you be able to give viewers a little bit of an introduction to you, sort of what your background is and how you came to be so interested in sort of health and politics in New Zealand?
Well, I've always been a bit of a political animal. I've always, for a long time, followed politics. I initially trained as a teacher, but never got to the classroom, probably beneficial for the nation's children, because I got diverted into advocacy work, initially working for the New Zealand University Students Association, and then, excuse me, and then in a educational organisation, and then working for the Primary Teachers Union. But for then over 30 years, I was the founding executive director of the Association of Salaried Medical Specialists, which was the first time that senior doctors had a union. And I continued that right up until the end of 2019. And which was good because COVID came a few months after that, and I was fortunately not in that role at that time, to which I'm rather grateful. But when we first started, we were much more pay and rations, focusing on doctors and primarily specialists working in public hospitals, not exclusively. But we, at that time in the 90s, the government of the day embarked on what was called the internal market, and that is that competition should drive the health system and the structures around it should reflect that. At the same time as we had decentralised collective bargaining, and I was the advocate in all of those, in all of the public hospitals. And so during our adjournments, we invariably discussed not so much pay and rations, but what was happening with the health system. And then that grew and grew. And I just got fascinated by it, the complexity of the health system, and increasingly the politics surrounding it. So I was fortunate enough to work for the ASMS in a way that gave me scope to think out loud about these issues. And I was fortunate to have international contacts, particularly, for example, with the British Medical Association. I went there several times, and a number of think tanks around in the UK, the King's Fund, the Nuffield Foundation, and also the London School of Economics, and particularly the London School of Hygiene and Tropical Medicine, which has got a very strong health research facility. So those things just kept enabling me. So I guess you got to say, Gary, it became addictive.
And you were the head of ASMS for a long time, I think literally decades. Yeah. And I should mention that I'm a member of ASMS. What that really means is the Association of Salaried Medical Specialists is kind of a long acronym, but it's essentially the public hospital doctors and the public specialists. And it doesn't deal with private practice, for-profit, or anything like that. It deals with the public hospitals. I'd like to move us to the article that you just wrote in Otaihanga Second Opinion, which is your blog, of course, on health and politics and related issues. It's entitled, Who Benefits from Outsourcing? I'll try to pop it up here on the screen for people watching. Who benefits from outsourcing planned surgery? Follow the funding. I think it's worth just mentioning that the Health Minister, Simeon Brown, has announced his intention to privatize all public hospital elective surgeries. That's something like 10,000 of them a year. And to essentially do that by putting money out in the private sector. So what I think of as money that could have gone to fixing the shortages and understaffing in our public hospitals, now being diverted out into the public sector to pay for knee surgeries, hip surgeries, cataract surgeries, that sort of thing. Can we talk about that for a minute? Because I think to the average member of the public, they say, what is wrong with this at all? How is this not an unalloyed good that I would get my cataract surgery or my hip surgery faster in private in a couple months right now? What is wrong with using taxpayer dollars for that? Is there anything wrong? I have some opinions, but I'll let you go first, Ian. What do you think?
Well, if it was as simple as you outlined, then there'd be nothing wrong with it. But that's not the reality. You've got to dig deeper than that. And what is happening is that the only reason why there's an imperative to outsource elective surgery, and what we're talking about, it's not even all elective surgery, it's the less complex. And it does tend to favour those procedures, such as cataracts, that are almost factory-like in a way, but high volume, less complex. And so it distorts the system, but it means it enables cherry picking. But more importantly, the reason why it's happening, is a combination of two things. One is, political ideology, and the other is the rundown of the public system, particularly public hospitals in this context, that's been going on for some time over successive governments. And it is conditional, its success, its dependence is driven by the rundown of the public system. If our public system was sufficiently staffed with the specialists, with the surgeons, with the anaesthetists, with the pathologists, with all those that do diagnosis, and all those that, on the medical side who treat patients physicians. If we were well-resourced or sufficiently resourced, we would not be in this predicament. We would not have people queuing up trying to get access. So it's dependent on the rundown. But the problem with it is that it then, by particularly getting into these longer-term contracts, which is really a form of public-private partnerships by a different name, what we're doing is that we are perpetuating the rundown. So the rundown contributes is a lead factor in causing this to happen, but it also gets the rundown. Then the outsourcing perpetuates the rundown as well. So it goes back and forth, self-fulfilling. What it means, though, is that we're going to have more specialists who are particularly surgeons and anaesthetists who will either go completely into the private sector, or they will reduce the time in the public sector in order to have more in the private sector. And I don't blame those people for doing that, because there's a limit to how much fatigue you can go through and put up with. And there's no doubt that if you are working privately, it's easier. It's obviously more remunerative by a country mile, but it's also less pressured. It doesn't have the advantages of the teamwork and the collegiality that go in the public system, but there are other things that can compensate for that.
So I'd like to quote Ross Pochin. I don't know if that's how she pronounces her name, but she's the chair of the New Zealand Committee of Royal Australasian College of Surgeons. She said most surgeons are already working long hours, including evenings and weekends. There are some surgeons who work purely privately. Of course, we know that's the minority, but most work privately and publicly. So there isn't a cache of private surgeons sitting there twiddling their thumbs in the evenings and weekends who can suddenly call in. She added that most surgeons were already working long hours, including after hours. There's only 800 of us in the country. We already work out of hours, as we all do on call. I'm about to start a week of continuous on call myself, which I'll do 81 hours straight, day and night. And so we get very little time off as it is. So what you're saying is there's going to be a hollowing out of the public sector as these surgeons and anesthetists and theater nurses leave public to go work in private, right? Following the taxpayer dollars into private.
Yes.
In addition to that, your article mentioned that there's an expectation that the public doctors that remain would actually work longer hours to pick up additional, what are called like extra duties, doing clinics and surgeries in the evenings and into the night and on weekends and holidays. Speak to that for a second, because it sounds unsustainable.
Well, I think it is that's because it is unsustainable. I think that it would be much less attractive. We depend a lot on international recruitment, but even with the ones that we train and seek to as medical students and then as resident or junior doctors, many of those are incentivized now to go overseas. If they are less likely to want to work in our public hospitals, if what they see is a fatigued workforce that's left behind, who would want to do that? Why not just simply go across to Australia?
It also begs the question of, is the solution to just keep creating third and fourth and fifth medical schools if you're not retaining the doctors you have? If you're losing them at a rate of knots, it doesn't matter how many you create or how many you crank out or how many you import. If you can't keep them in the public hospitals, it's just a waste of money, isn't it?
It is a waste of money. And it also goes the other way as well in terms of those that we recruit. Many of the people that we recruit from overseas, quite a sizable chunk of them leave within the first 3 to 7 years. They've gone. Not necessarily to Australia. In many cases, they go back to the country from whence they came, as I understand it. So that's not cost effective either. And we're not.
Yeah, the data on that is apparently within 2 years we lose 40 to 60%, depending on the DHB or the region you're talking about. It's an enormous loss.
Yeah, it is enormous. And the reason for that is the reason why you and your colleagues were on strike recently, and what's been repeated in other hospitals throughout the country, is that you don't have terms and conditions of employment that enable you to be able to recruit and retain a safe level of work specialists in a public hospital. And that's another issue that has to be addressed, but is not being addressed by a government that is indifferent to what happens to the public system, because their mantra is what's good for the private health system, and particularly for the for-profit private health system, is good for the health system. That's a bit like, you may recall historically, the expression of General Motors: what's good for General Motors is good for America. This is what we have here as an adaptation of that.
Wow.
And it's flawed.
I like that phrase, use recruit and retain, because you've really got to do both. It makes no sense to just crank them out if you can't retain them. And this is really the epitome of putting profits over patients, which is something we talk about. It's a sort of a mantra, but we're seeing it play out in real time. May I ask you about two other things? You, in your article, and I'd recommend everyone read the Otaihanga blog that you run, Second Opinion. It mentioned cancer drugs. I think I've got this highlighted somewhere. From the 1st of July, taxpayers would foot the bill for cancer drugs administered in private facilities for private patients. Now, we know the government talked a lot about wanting to afford these new cancer medicines. Can you speak to this angle, though? Explain it to all of us. I want a little clarity on this. Private cancer drugs administered in private facilities for private patients using public taxpayer money. Is that correct?
Yeah, that's right. For a 12-month period, for the first 12 months. Look, I think at the end of the day, if you had to simplify it, and it's the theme of my whole theme, is how the decision making is weighted towards benefiting the for-profit private sector. In this instance, the beneficiary is private health insurers. Because many of the people who will be going to be treated privately are either people that have enough savings of their own to do so, or have private health insurance. People who can't either save a lot or can't afford private health insurance don't get a leg in this at all. It's essentially a backhanded subsidy to private health insurers.
So if you don't have private insurance, or you're not quite wealthy, you can't access this. So it's a publicly funded
Yes.
cancer
Yeah.
drug that's only available to the wealthy and sorted, the ones who have
Yes.
insurance or just a pocket
Correct.
full of
Correct.
thousands of dollars.
Yeah. Yeah.
That's
This is
wild. I
different.
can't believe that this isn't a bigger story.
This is yeah. Well, I think we've just got to be grateful that we have Radio New Zealand as a public institution that does the level of reporting that they do. Otherwise, these things would not come out.
I mean, potentially not for much longer, because the
Yeah.
whole ACT neoliberal Atlas sort of gist is to get rid of public media, to defund, like what you see
Mm.
going on now in the States. I think there's a push even in New Zealand by some in the right wing, especially the sort of Seymour type folks, to eliminate or at least massively hamstring places like RNZ.
Yeah.
In which case, I guess these stories will really not come out.
Yeah.
So that's awful. The cancer thing. It's just unconscionable. Thank you for alerting us about it. Can you speak for a moment about another thing you cover here? This idea that I think it was 100. Is it 150 million dollars going into private urgent cares and things like private telehealth
Mm.
instead of the public sector? But the private telehealth companies and urgent cares, in this case, I'll just read the quote. A telehealth provider offering a new online medical service would receive $65 for a consult with a 14-year-old casual non-enrolled patient whose caregiver holds a community services card. In contrast, a general practice, so a general practitioner, would only receive $20.45.
Mm.
So more than a 3 times increased rate of reimbursement to the private sector, which is a corporation, which is a for-profit corporation, how do they explain paying the private
Well,
sector
their
doctor 3 times
explanation,
as
it's a
much?
sleight of hand. Their explanation is a sleight of hand. For their enrolled populations, general practices are paid according to capitation, which is based primarily per capita, per head of enrolled population, weighted somewhat by age, and also for women who of an age where they might become pregnant. So there's a weighting there, and two adjustments. It's a crude system. It's better than what we had before then, and it doesn't sufficiently recognise complexity, but it is basically population based. Now, if they are using that formula, and the other thing that general practices get is for the unenrolled people who turn up as casuals, and that's often after hours, and they get a smaller amount for that, much smaller. They are using the higher rate for routine. The ministry on behalf of government is using the higher rate that's generated by capitation for casual patients rather than enrolled patients, and they should be using the same casual rate as they're using for that they pay GPs at the
Wow.
moment.
So that way they're able to shunt out approximately 3 times as much money to these private corporations.
Yeah,
Which in the case of something like White Cross Urgent Care Center
yeah,
is actually owned by private equity. It's based in Sydney. It's a multinational corporation. So this is not your mom and pop's GP sort of practice. This is the corporate inroads into healthcare in New Zealand. It's amazing that,
well,
honestly, that they've managed to do
yeah.
so much so quickly. It's really shocking.
Well, they're taking the opportunity. They're taking the opportunity, and I've got an article in for publication with Newsroom that hopefully will be published at the end of the week or over the weekend, and it's looking at just the issue that you've raised, but particularly the corporates. And White Cross comes under the wider umbrella of Green Cross Health, which is the largest corporate general practice owner in the country, and they. They and another one called Tend Healthcare, which has a particular focus on telehealth, have been able to become primary health organisations. They don't believe in private health organisations. They believe they should be able to directly contract with government for their own funding. But by
Primary
becoming
health
a
organizations,
PHO,
right? Yeah.
yeah, primary health organisations are bodies that established by policy rather than statute, but they essentially, the most visible function is funding the general practices enrolled populations. But they do a lot of other things as well in terms of IT support, in terms of rescuing practices that get into difficulty, and also a focus on population health. Now, corporates are trying to take that over, and in order to maximise profits, and that comes into play as well. But you'll have to read my article on that when it's published,
We will. We look
and you may
forward
want
to
to
it.
do another podcast.
Yeah, we may have you back to talk more about it.
Hmm.
All right. So to recap, we've got public patients unable to access cancer meds that are publicly paid for by them. So this is taxpayer funded cancer meds, unless they have private insurance or a pocket full of money. And that's going to go
Hmm.
on for a year. We've got GPs making 3 times less than these telehealth and urgent care contracts. We've got urgent care companies that can trace themselves onto ownership under things like Mercury Capital, so big multinationals. And we've got 10-year contracts being given to the private sector when we have nothing like that assurance within the public sector. So, and we've got the privates
Hmm.
cherry picking cases, surgical cases, doing the most profitable, easiest things for the highest rate of pay, pulling our surgeons and anesthetists and other doctors into the private sector, weakening our public sector. would you say I've summarized your article up adequately?
Yep, absolutely.
Does that cover? That's a lot. Any one of those things should be a
Very
national
well.
outrage that we fight against.
You may have
The
all.
fact that it's coming
It's
so
almost as if
fast
you were
and
the ghost writer.
it's fascinating how
So you're
quickly these
cutting out.
things are happening, to where if we wait another week, there will be one or two more dreadful stories coming out that we'll need to comment on. The rate
Yeah,
of dismantling of the
yeah.
public health infrastructure and staffing is really unbelievable. Do you see a solution in any of this? Do you see a way to fight it or stop it or speak out against it? I mean, obviously you're writing articles as fast as you can, but what else can the public do?
Well, I think the public need to be take every opportunity to exercise their voice on it. If you had to say what is the most important thing for the health system, or one of the most important, it's voice. The voice of the public, the voice of health professionals, the voice of their various organisations, both the professional bodies and the health unions. That's also critical. But when I look back over the 35 years or so now, if you include the half decade that I've no longer working in it as such, the thing that has made the difference, for better or for worse, has been the ideology and the, I guess, the competence of political leadership. That is more than anything else. And so what we desperately need is a change of political leadership in health that recognises that health is not a commodity, it's a public good. And everything that the public will want to call upon at any point in their life, including their families, their whānau and friends and colleagues, at any time in their life. And we have to have that being reflected in how the system operates, its leadership culture, and in its structures that are wrapped around to help to enable it to happen. But we need a shift in political leadership.
Yeah, those are sage words. And it makes me think that there might be listeners who are young and healthy and who think it doesn't matter to me one way or another. But at the end of the day, it does matter to you. We're all going to age. We're all going to have accidents and emergencies and end up in an emergency department or in an ICU or in a medical or surgical ward or need a public hospital surgeon. And if we are degrading the system and making it unstable, that's not the way you build a better nation. This looks like a one-way track
No, it's not.
to a horrendous situation. So I want to thank you
Well,
for
there's
doing
been
what you do and writing your articles, because it's essential. Thank you. No,
it's
did you
very
want to say
therapeutic.
something? Yeah, it's very therapeutic.
Oh,
Did
I
you
was
want
just
to
going to
add
say that,
anything to wrap this up?
well, I guess a comment to make as well is that it's been recognised by really radical organisations like the International Monetary Fund and the OECD, that investing in health is good economic investment in the economy as a whole, including in developed nations economies such as New Zealand's. And if we could shift the mindset of government to recognising that, then we would have a far better health system, because you are not only doing good for people, you are doing good for the state of the economy. And if you're doing good for the state of economy that benefits all, then you are benefiting the public as well. So we should always never forget these linkages. It's not health in isolation. Health is critical. A good health system is critical to a good functioning economy that benefits all.
Couldn't have said it better myself. Beautiful. Thank you. Thank you for doing what you do. I appreciate it very much. And thanks for coming on the front line. We'll have you back again when your article hits the papers.
Okay.
Thank
Thanks
you,
very much,
Ian Powell.
Gary.